our guest speaker will be coming in a minute. He is Dr. Joseph Carnan. Before that, can we start and every group just in one group sentences introduce themselves?
I am Dr. Rizwan Naeem. I'm in New York, and part of the team with Aziz Kumro and Fiza Jilani.
And Dr. Aziz Kumro, I will ask if you can introduce everyone. Dr. Aziz Sumru, can you please start introducing every group? Dr. Sumru, Dr. Aziz Sumru, आप प्लीज सबको इंट्रोड्यूस करवा सकते हैं डिफरेंट ग्रुप्स को?
I don't know whether he is listening.
Introduce everyone. We are online. Everyone is online.
आप बेशक उर्दू में, सिंधी में, किसी भी लैंग्वेज में इंट्रोड्यूस करवा लें अपने ग्रुप को.
Hello. Hello, I am Dr. Moin Siddiqui. Can you listen me?
Yes, we are listening.
I am Dr. Moin Siddiqui. I am director of the Syed Abdullah Shah Institute of Medical Science 7.
Okay, right. Thank you very much.
My institute is located in the mid of Sindh. It is a multidisciplinary hospital providing healthcare services at both 5 districts of the mid Sindh. We are providing services on curative and curative side also. Thank you.
Thank you very much.
My name is Dr. Nisar Sumro. I'm a consultant anesthesiologist, King Faisal Specialist Hospital, Riyadh, Saudi Arabia.
Thank you. Shukriya बहुत बहुत.
Dr. Mar, go ahead and introduce yourself. Dr. Mar. Dr. Mar, go ahead and introduce yourself, please. Okay.
Hello.
Mr. Babar, can you mute your microphone? Mr. Babar. Mr. Babar.
Who is this Babar?
Dr. Scott. Doctor.
Okay, everyone, can you please mute your telephone so we can start our speaker, so we can start our presentation? It's very hard to hear anyone because so many groups are speaking, so please mute yourself. So first of all, we want to say all views expressed in these webinars are of individual presenters and do not represent views of any institution. Number two, this is a volunteer project aimed to reduce stigma and increase awareness about HIV disease in Pakistan. No one is hired and paid by any institution to do so. Our group does not affiliate itself with any political, ethnic, or religious denomination. So the rules during the presentation are all computers are mute and only host and two co-hosts, which is Dr. Rizwan Naeem and Dr. Aziz Sumru, will be on. So, and please write your questions in the right-hand side panel. And please ask questions relevant to today's topic only and keep them brief. Dr. Sumru will handle the questions after the presentation. And our request, please fill out the evaluation forms sent to you after the webinars. So today's webinar is introduction from 12 to 12:05, and then Dr. Joseph Garland will be talking about HIV Care Cascade, and his discussion will end around 1 o'clock. After that, we will continue our HIV stigma provider-patient communications, which we have been doing since webinar 1. So our HIV communication project overall goals are to reduce stigma and increase awareness about HIV disease by empowering healthcare providers with HIV disease knowledge and ways to improve patient, provider, and families' communications in Pakistan. Review of previous webinars. In webinar 1, we discussed very basic HIV knowledge and different aspects of HIV disease, including definition and disease progression, stages, symptoms, and transmission modes in general and specific to Pakistan. We also discussed myths and facts related to HIV disease in general and specific to Pakistan. In webinar 2, our guest speaker, Dr. Phil Chan, discussed standards of HIV testing in general and in resource limiting settings. And he also discussed required lab testing for disease management and standard precautions related to HIV lab procedures. And last half an hour in every webinar, we dedicated to discussion on the importance of open communication between healthcare providers and patients about the HIV disease. So webinar 3, today we'll be discussing HIV Care Cascade, and Dr. Joe Garland will be talking about our own HIV clinic, outpatient HIV clinic in Rhode Island. So Dr. Joseph Garland, he completed his undergrad and medical degree from Harvard University and residency and fellowship training at the University of Pennsylvania. He is Associate Professor of Medicine at Brown University Medical School and is the Medical Director of the Infectious Diseases and Immunology Center at the Mariam Hospital in Providence, Rhode Island. He oversees the outpatient services of the Infectious Diseases Division, including the federally funded Ryan White HIV Care Program and the Travel Medicine Clinic. He co-chairs the statewide 90-90-90 collaborative for improving HIV outcomes in Rhode Island. So I'm giving mic to our dear guest, Dr. Joseph Garland. So.
Thank you, everyone, for having me. I wanted to sort of talk about two areas today. So Dr. Gilani and I work together, and there's sort of two areas that we thought I might be able to sort of at least explain what we're doing here. One is to talk about the HIV Care Continuum here in Rhode Island, and then sort of and with my role with the 90-90-90 collaborative. And then secondly, to talk a little bit about our clinic and sort of how we set up clinic, how we move patients through clinic, through my role just as the medical director of the clinic. So I wanted to start with the first subject, talking about the HIV care continuum, a little bit of background on global context, and then a little bit about sort of what we are doing here in Rhode Island. So many people have probably already heard of the HIV care continuum. It's also been called the treatment cascade, and it was something that was really first proposed in 2011 in a landmark paper in MMWR. And the investigators really tried to look at all of the different stages of HIV care. So trying to estimate the total HIV infected population of the United States, moving to seeing what percentage of that population has actually been diagnosed. In terms of the population that has been diagnosed, how many people have been linked to care, meaning they've ever been connected to care, and then how many people have actually been retained in care. Once you have folks who are actually retained in care, being seen in clinic regularly, how many people are prescribed antiretroviral therapy, and then our ultimate goal really is virologic suppression, because that is both important for the patient's health as well as from a public health perspective. We do know that people who are undetectable are unable to transmit to others, so it serves both the health of the individual and the health of society. And as you can see from the diagram from the original Care Cascade published in 2011, so disappointingly, about 28% of the U.S. population who was presumed to be HIV infected was actually diagnosed, linked to care, retained in care on antiretroviral therapy, and then actually made it to that last step of being virologically suppressed. The biggest step off, as you can see, really are between the second and the fourth column. From diagnosis to retention in care, you lose almost half the population, and that both in the U.S. and globally remains the most difficult step of getting people from diagnosis to actually staying linked and getting linked and then staying retained in care. The key components of the HIV care continuum really can probably be boiled down to fewer columns. Really looking at what percentage of the total population that's HIV infected is actually diagnosed, what percentage is actually retained and in care and treated and offered antiretroviral therapy, and then what population is virologically suppressed. That concept is really what led to the 90-90-90 campaign. It is an international campaign, as many people already know about, really led by UNAIDS, with the goal being by 2020, which I realize is very close, and may be revised to 2030, but 2020, of having 90% of all people living with HIV worldwide know their status. From there, 90% of that population who's diagnosed be engaged in care and be prescribed antiretroviral therapy. And then of that population, having 90% of that population offered therapy actually virologically suppressed. Again, that offers incredible benefit to the health of the individual, but also from a public health perspective to the risk of transmission across society. So how are different countries, different cities, different jurisdictions going about this? One of the major ways is through the Fast Track Cities initiative. from really launched by UNAIDS and the International Association of Providers of AIDS Care. We are part of that initiative, the Fast Track Cities initiative here in Rhode Island. So both the state of Rhode Island and the city of Providence have signed on to be part of 90-90-90. Which means that we have a statewide coalition of people saying, how can we try to get this? How can we get to this goal? Where we are in Providence are the numbers across the bottom. So we've actually reached 91% of the patients in the in the city of Providence diagnosed based on CDC estimates. About 79% are in care and offered treatment, and about 79% of those are on treatment. Of those who are offered treatment, about 91% are virally suppressed. You can see that even with all of our efforts, there's the biggest drop-off is really between those who are diagnosed and those on treatment. If you look at the population on treatment, 91% of those are virally suppressed. If we get people engaged in care and on treatment, they get virologically suppressed. So that's where we are for the city of Providence. The 90-90-90 campaign, I think just to talk about how much of HIV care is not just doctors and patients, but really setting up a system for success. I think this is an example of that. So this is really, so I co-chair the 90-90-90 campaign with the director of the HIV division of the Rhode Island Department of Health. And the Rhode Island Department of Health is really pushing this initiative. As I've said a couple of times already, there is a very important public health goal of getting people who have HIV diagnosed in care and on treatment, both for their own health and for the health of the community in terms of reducing risk of transmission to others and overall community health. So the federal and state Ryan-wide programs are also involved. So the Ryan-wide programs, I should explain. So Dr. Gulani and I both oversee the Ryan-wide program here at the Miriam Hospital. It's a Ryan-wide program is a federal program that provides federal assistance to clinics seeing people regardless of insurance status, ability to pay, or immigration status here in the U.S. who have HIV. So we oversee the Ryan-wide program. So several health centers, including ours, are part of the campaign. And honestly, probably most importantly, several social service agencies are there because we think about the social determinants of health. If we think about the barriers to care of our patients, they largely, most people would rather be healthy than not, and they want to engage in care. And really the struggles that they have are, some basic needs around housing, around counseling, around mental health, substance use disorder, around transportation, making it how to get to the clinic on a very limited budget. So the social service agencies are really key in achieving 90-90-90. You really can't get there without these agencies coming together to support patients to get in the door. If they can get in the door with you, as you can see from our numbers, people generally want to take care of themselves, want to be on medication, want to be healthy, but there's so many sort of social barriers to that. There are patients also involved in the 90-90-90 campaign because that's the key perspective is having individuals who are directly affected by HIV involved in policy setting and strategic planning for how to get to where we need to be. And then there are many others. There are folks from the housing department, from the state of health, there are folks from the city of Providence, etc. So that's sort of an overview of the 90-90-90 campaign for anybody who isn't already familiar with it on a global scale. And then a little bit of a local perspective about how we've brought the key players together and where we are currently. As you can see, we have not yet achieved 90-90-90 here in Rhode Island, so I am certainly humbled by the experience. We've been working on this for the last 2 or 3 years. Dr. Gulani pulls numbers. We are getting better every year, but we are still not there. If that is helpful, that's sort of my perspective on where we've come. I also, we can have some discussions on, so if you have any questions on that, I'll hold those thoughts or write it down. I also wanted to talk to you a little bit more concretely about our own clinic and our own perspective is from caring for a large urban HIV-infected population here in Rhode Island. So this is really talking about our clinic, sort of with me wearing my hat as the medical director of the clinic. So just a reminder, this is a slide that Dr. Galani has shared in previous presentations, really talking about HIV disease progression and stages. For those who may not have made it to some of the earlier webinars, just a quick reminder, if we sort of imagine on the left-hand side, a person before HIV infection, if you were to draw a blood sample, you would see, a regular normal CD4 count, you wouldn't see any HIV virus. At the time of infection, during acute infection, there is a large rise in viral load. People can have viral loads in the millions. And you get a usually significant drop in CD4 count at that time, while your immune system really struggles to reach a balance with this virus. Then there really comes a period of chronic infection, and there is a broad range of clinical presentations of that. Most people are asymptomatic. The average time from time of infection to AIDS to symptomatic disease is around 8 years, but that's very variable. There are rapid progressors who can progress from infection to advanced disease in a year to 3 years. And there are people who we call chronic non-progressors and elite controllers who tend not to progress even after a long period of time. But the majority of people fall somewhere in the middle in chronic infection, which over the course of years, the CD4 count gradually falls, as you can see represented by the decreasing number of white blood cells in the test tubes here. And the viral load gradually rises. It's not a passive process. This is sort of a constant battle being waged in the blood, that there's constantly virus infecting CD4 cells, lysing CD4 cells, producing more virus. Meanwhile, your immune system is constantly trying to produce CD4 cells. But over time, the total body CD4 lymphocyte count drops because of the cells are just being eaten up faster by virus than your body can produce. And eventually people end up in a situation where their viral load really is taking off and the number of CD4 cells present is low. Generally a CD4 cell count less than 200 cells per microliter is really what we look at for a diagnosis of AIDS. And that's really where you just have inadequate CD4 positive cells to ward off infections. If you remember, our immune system, and I say I'm a clinician, not an immunologist, so forgive my basic description here, but if you imagine different components of our immune system are responsible for defense against different types of pathogens. Your CD4 cells are responsible for some specific pathogens, and when your CD4 count is low, you are at high risk, not for every disease, but certainly for many diseases that really require a CD4 response. So we commonly see pneumocystis, lung infections, we see cryptococcal infections, we see tuberculosis with advanced disease. So that's just sort of a quick reminder for anybody who hasn't been on the previous webinars about HIV progression. Our goal really is, in the 90-90-90 initiative, is with that first test tube example here, really to catch people before, all the way over on the left here, to catch people before they get infected and try prevention. From time of infection, we really want to catch people as early as possible diagnostically. So in the next test tubes, we'd rather catch people during acute infection or during early chronic infection. The later the infection progresses, obviously, the poorer the health of the individual and the more risk they will have had to transmit disease to others. So in 90-90-90, really that first 90 is getting people diagnosed. The second 90 really is to reverse the arrow. It really is to say we want to get people into treatment on medication. So rather than the natural progression to AIDS, we actually reverse it and send people back towards essentially where they would be here, where they still are HIV infected, but their virus is suppressed by the medication. So on a blood sample, you don't actually detect HIV virus. Their HIV test will still be positive, obviously, because they still will have antibodies, but their virologically behave like their virus will be suppressed, and their immunologically behave very similarly to people who are HIV negative and have good health. Okay, so a little bit of background on us. So the Immunology Center at the Mariam Hospital proudly serves over 1,800 people living with HIV, which is estimated to be over 80% of the population of people living with HIV here in the state of Rhode Island. So Dr. Gulani and I have the privilege of caring for the vast majority of the people in Rhode Island with HIV. Our clinic is staffed by 23 physicians, a nurse practitioner, and 2 physician assistants. That seems like a lot of doctors. Several of the doctors are researchers, so they don't actually spend a lot of time in clinic. That's why there's so many of us. But importantly, to my earlier point about really taking a community to care for people living with HIV, our team includes medical case management nurses, social workers who can really help with some of the barriers to care, a psychologist and a psychiatrist, because the reality is there's certainly a lot of comorbid mental health disorders with HIV. Having a mental health disorder puts one at higher risk of acquiring HIV just through potentially higher risk behaviors. And also just the diagnosis of HIV is a major psychological stressor for patients, as you can imagine. We also have patient navigators, so people living with HIV who can actually help our patients connect with our patients. And then we have outreach workers, so people who can help with insurance, can help with sort of navigating how to get to a service agency. They come into the outreach worker and say, I'm having a housing issue. So what are the housing resources available, et cetera. And importantly, we have pharmacists, because there are some important drug-drug interactions, drug toxicity, et cetera, that we want to be able to be on top of. We are an active site for HIV research trials. Several of our faculty are on national boards, not me, but several of our research faculty are on national treatment algorithm guidelines. You're going to be hearing from some of them in future webinars. Just taking you through the path of the patient coming into clinic. Diagnosis, happens in the community the vast majority of the time. It can happen at the walk-in clinics. It can happen at STD testing sites across the state. The Department of Health really encourages testing at high-risk areas. So in the United States, there are certain higher risk populations, including men who have sex with men, sex workers, people who inject drugs, and so we offer testing at places where those individuals might come in for a visit or for anything else, so non-medical sites. When someone's diagnosed, they call the clinic, they speak to the nurse. We can usually get someone in for a same-day appointment or within the next couple of days, and that's important, linking people to care. If you remember the care cascade, the biggest drop in the care cascade is from people who get diagnosed to people actually getting connected to care and retained in care. And the longer people wait, the less engagement they will have. So we try to get people in as quickly as possible to meet with our nurse. They get a lot of education about what's true and not true about HIV. They get their labs drawn. And some people will actually even start on medication that soon. So we really try to get medications in front of people as quickly as possible. Their first appointment with a clinician will usually follow within a week or two, at which point we review all the labs. And we really spend, I will say, I spend a lot of my time counseling patients. I have a slide on that coming up next just to talk a little bit about what we talk about. And I generally do try to start people on medication. Those of you who've been in HIV care for a while will probably remember this is a departure from what we used to do, which is we really used to wait for a certain CD4 count before starting medications. We used to look for signs of sort of needing to start medication. But both for the health of the individual, multiple studies have shown that starting earlier has important health outcomes, has a mortality benefit for people living with HIV, and for the public health perspective of decreasing transmission. So we really try to start people on meds as soon as possible. They follow up generally a month later to see how they're doing with medications, how they're doing with adherence. Adherence is a major struggle for particularly young people who haven't had to take a medication every day, so we really try to check in regularly around that. And then once people are doing stable, meaning they're undetectable, they're doing well on their medications, they follow up every 3 months. And then after a year, we actually usually move people out to every 6 months. The way our clinic is set up, patients are seen in the general infectious diseases clinic. I want to stress to all healthcare providers that this is sort of a message that we often have to remind our colleagues who are not familiar with taking care of people living with HIV, in our hospital system, that HIV is not contagious from any casual contact, and that so patients don't need to be separated into a separate clinic space. They're seen with all of our other general infectious diseases patients who are coming in for a hospital follow-up visit with their IV antibiotics, or who are coming in for treatment of Lyme disease, or coming in for treatment of hepatitis C or whatever. There's no special equipment, no special precautions needed. We see and examine them just like all other patients. We don't wear gloves. We don't have to wear any gowns. Casual contact is not a means of transmission of HIV, as you are all aware. In terms of when we do use standard precautions, that's around any time we're using sharps, and any time we're going to be potentially exposed to blood or body fluids. And by body fluids, I'm not including sweat, saliva, tears. As you know, those are not ways of transmitting HIV. So we use gloves for all phlebotomy procedures. We use gloves for all handling of blood and bodily fluids. We do not reuse any needles. We always use disposable needles. And we have sharps boxes. We have hard disposable syringe waste bins in all rooms, so that if you're drying any blood, or if you are using a tongue depressor and if the tongue depressor breaks, you can have somewhere you can throw it away to really decrease any risk of anybody getting stuck and injured. At our initial visit, I usually talk to people about all the things I would talk to any other patient about in terms of getting a good medical history, current medication list, doing a physical exam. All of that is standard. I do it the same way as with any patient I would in the hospital or any other clinical setting. In terms of laboratory testing, I really confirm diagnosis of HIV. You had a talk from Dr. Chan last week on that. Check renal function is, I think, key, just because of the dose reduction needed in some medications, and other diagnostic laboratory testing. An important thing for all people living with HIV is assessing for co-occurring disease. So, we run an adult medicine clinic, and you'll be hearing from a pediatrics post in the future. But in our clinic, assessing for tuberculosis, assessing for viral hepatitis, assessing for sexually transmitted infections is important, because there are diseases that tend to run with HIV, and those are those. So that's important. Non-infectious diseases, mental health, substance use disorder, etc., are also important. So we also do a mental health screen with all patients, both to look for pre-existing mental health disease, but also just for the psychological stress of a new diagnosis. I mentioned we have social workers and psychologists in clinic. They're key usually in the early stages of visits with people. We do a lot of patient education about HIV, which I'll talk about on the next slide. And we do a lot of patient education around treatment and adherence. The important pieces are pretty self-evident. Take the medication as prescribed. You have to take it every day. Unlike a blood pressure medication, missing a couple of doses of a blood pressure medication, in theory could be life-threatening, but generally isn't. The difference with HIV is we're actually treating a pathogen that can change and can adapt to antiviral exposure. So if you stop medication and restart it, as you know, patients have a high risk of developing resistance. And with limited treatment options, we don't want to have to move them to second line and third line regimens. So adherence is sort of a key component of all HIV visits. We consider starting treatment on the first visit, as I said. And we schedule a follow-up usually in a month. When I talk to patients about their education, about sort of education around HIV, it's sort of tailored to each patient based on where they're coming from, what they already know. So I usually try to start by asking people, what do you know about HIV? Tell me what you know so far. I think that if they have someone that they have disclosed their status to, I try to bring that person into the room. Sometimes it can be overwhelming to one person to remember it, so it's helpful to have someone else there. If there's a spouse, it's actually really helpful for the spouse to really understand what the risks are and aren't. I think fear drives people to overestimate their risk in the wrong areas and underestimate their risk in other areas. People who don't have medical backgrounds sometimes will look to the internet and sort of end up getting incorrect information, because there's a lot of really useful resources available through the internet. There's a lot of incorrect information on the internet as well. So I talk about that. I really focus with people that HIV is not a death sentence. People still have that idea in their mind even today. With treatment, people living with HIV have a normal life expectancy. I counsel people that any plans that you had made for your future, I would hold on to them. Those are still our plans moving forward, including if you want to have children, etc. There are things we need to talk about. So don't go out and try to do that immediately. But people living with HIV certainly can have can have children and have a normal life expectancy. We talk about getting on treatment. Again, as I said, both for the individual and for public health perspective, getting on treatment is important. So treatment improves morbidity and mortality at any stage of disease for people with HIV. Treatment is prevention. And the sort of campaign here in the U.S. is U equals U. So undetectable means untransmittable. People who are on meds and undetectable can't transmit virus to others. We talk about how HIV is transmitted, so blood to blood, for example, needle sharing, sex, maternal to child at birth, and breastfeeding are the main ways that I talk to people about how HIV can be transmitted to others. How HIV is not transmitted, I think, is important, particularly if there's a family member or spouse in the room. That HIV is not transmitted in saliva. You can't get it from kissing people. It's not transmitted in sweat, tears, urine. Really, the body fluids that we talk about as causing transmission are blood and fluids exchanged during sexual activity. Casual contact, hugging people certainly can't give you HIV, and you can't get HIV from public facilities like toilets, swimming pools. It is not transmittable by mosquito. It cannot survive in the mosquito. Skin-to-skin contact, etc. So all of these are ways that we as healthcare providers know, but that people living with HIV, who particularly newly diagnosed, who feel sick, feel like they are contagious, need to be reassured that they don't have to eat off of separate plates. They don't have to drink from separate glasses. They can still hug their children, their spouse. They can still kiss their loved ones, and they are not giving and transmitting any risk to others. In terms of treatment decisions, these are very location dependent. The U.S. generally follows the Department of Health and Human Services recommendations, which you can look up online at aidsinfo.nih.gov/guidelines. So this is what Dr. Gulani and I use in our clinic. We are required to because of our federal funding. And I will say that the U.S. guidelines are not particularly that different than the current WHO treatment guidelines, which were released at the end of 2018. Really looking as a sort of interim guidance, focusing on shifting first-line therapy to integrase inhibitor-based regimens. It's probably more than the scope of this talk to go into that extensively, but I just want to show you those are the guidelines, which are also available online from the WHO website, and the guidelines focus. You guys can see my arrow here, but focus on for men in general trying to offer tenofovir plus tenofovir plus lamivudine or emtricitabine with dolutegravir, which is an integrase inhibitor. Alternative regimens, tenofovir plus lamivudine or emtricitabine with efavirenz, and then in some situations, AZT, lamivudine, and efavirenz. I believe from what Dr. Gulani has shared with me that integrase inhibitors are not widely available in Pakistan right now. So most people are probably using either this alternate first-line regimen here or the sort of special situations regimens based on drug availability. But looking to the future, dolutegravir is actually generally relatively inexpensive and has a very high barrier to resistance, very good tolerability, so it's an excellent treatment choice. If that can become available. And there are over 80 countries around the world that have moved to using dolutegravir-based regimens. So the US and Europe, Australia, and New Zealand generally, most countries have, in terms of countries in the developing world, Brazil, Botswana, Kenya, several other countries have moved to dolutegravir-based first-line therapy. There is a warning around dolutegravir in women who are of childbearing potential, and Dr. Kulin will talk a little bit more about that coming up. But that's probably going to go away depending on the results of the upcoming study that's just concluding. You'll actually have a talk specifically on care of women. I think. I know people have actually put some questions up, so we'll try to get to questions in a second. Again, I'm not going to go too much into treatment. I would say that the important things to think about are what is your sort of standard go-to treatment regimen? What are situations in which you'd want to do an alternative, and what is that alternative? And then sort of the important thing is what is your second-line regimen? In most places, there are standard sort of first-line regimens and second-line regimens, and in these same guidelines, there's actually WHO guidelines for standard first-line regimens and standard second-line regimens. So I recommend the WHO guidelines to folks, and I apologize I didn't put the website on here, but we can put that on the next set of slides. All right, I think that's sort of the background on stuff that that Dr. Gawani had asked me to talk about. I know that folks probably had some questions, and I saw a bunch of questions sort of flash up as I was talking, so we can try to go through those. Let's see. Let's see. Down to which direction do we start? Okay. So TB is very common in our society. So I'll just read out the question and then try to respond. So TB is very common in our society. Should we consider like every patient having, or HIV patient having TB until proved otherwise? Oh, do they want to see me talk? Oh yeah, sure. Hold on 1 second. We'll switch so you guys can see me on the webcam. All right. Hopefully folks can see me here. I can't see myself, so please, somebody message me if I have something hanging off of my face. So the question was, TB is very common in our society. Should we consider every TB as having HIV until proven otherwise? That's an interesting question. I would say that yes and no. I would, from the perspective of should everybody diagnosed with TB be tested for HIV? Yes, that is something that in general is recommended. Because people living with HIV have such a higher risk of having tuberculosis. So if you diagnose someone with tuberculosis, yes, I would recommend testing them for HIV. I would not necessarily assume that they have HIV, meaning I wouldn't send additional labs or start them on therapy, etc. But yes, I would recommend diagnostic testing in all people who are diagnosed with tuberculosis. And in areas with high tuberculosis endemicity, all people living with HIV, the WHO does recommend screening for tuberculosis, and there are actually guidelines on starting people on isoniazid therapies actually for people who do not have tuberculosis in high endemicity countries, of actually starting them on isoniazid therapy as prevention. Okay, if you have more questions on that, please feel free to just throw another question up there. I'll see if I can scroll through these. I apologize. Down. Our society does not have a well-built GP system like any Western countries. I will say that is not uncommon. So I have not worked in Pakistan before, so I can't speak directly to suggestions for you around that. Dr. Gawani probably could offer something. I worked in other settings, including my mother's from Thailand, so working in Thailand, and then in Botswana and Kenya. And, for example, Botswana, which has a very high, a large HIV epidemic, really built the HIV system sort of separate to or parallel to a primary care system, and really offer GP services sort of wrapped into the HIV care model. So they have a clinic where people come for their HIV care, but while they're there, they get their gynecologic screening, they get their blood pressure treated, etc. That's actually what we do at the immunology center here as well. So many of our patients actually get their primary care in our clinic as well. So though we treat their HIV, we also serve as their GP, and then we treat their diabetes and hypertension. It actually makes a lot of sense because There are important drug-drug interactions. There are toxicities to the meds that we would recognize as HIV providers that a GP might not, and sometimes the fractured care of having multiple people engaged can actually, or multiple providers engaged can actually be a detriment to patients. So I would say I wouldn't see that as necessarily a barrier of not having a GP system set up. If the HIV clinic can serve that role, and there are models both here in the U.S. And in countries around the world where that actually works really well, and I'm a big supporter of that in general. Which virus is considered more risky, HIV or hepatitis? So it's interesting. In terms of transmission, sort of risk from a needle stick injury, far and away the highest risk is hepatitis B. And I can't remember the exact numbers, but I think it's if you have a needle stick from someone with hepatitis B, you have up to a 30% risk of actually acquiring that from that needle stick. HIV, so hepatitis, viral hepatitis, hepatitis C is actually higher risk, the next highest risk of transmission, but much lower. It's around 3% from a single needle stick injury, and then from HIV, I think it's around 0.3%. And in terms of, so for someone getting a needle stick injury, you'd be most concerned about hepatitis B, second most concerned about hepatitis C, and least concerned about HIV. It certainly does occur or has occurred, but it's actually very uncommon for injury to the provider from that. Oh, I'm sorry. I will come closer. In terms of risky from a patient perspective of having those diseases, that's a more complex question about, I'll say HIV makes hepatitis B and hepatitis C worse in terms of disease progression, risk for cirrhosis, risk for hepatocellular carcinoma. All of those rise with HIV co-infection. In terms of which of the three is most likely to progress to disease that have the most morbidity associated with it, I don't know that I could give you a fair answer to that. I would say that treated HIV would be the lowest risk, but untreated HIV versus untreated hepatitis C and untreated hepatitis B, I don't know I could give you a fair answer on that, sorry. On average, how much would the cost to treat one patient having diagnosed with HIV be, please? So I actually can't give you a fair number for this because it's very country dependent. Yes. So in the U.S., yes. So Dr. Gulani is right. In the U.S., it's $36,000 per year. That is not true outside the U.S. Drug costs in the U.S. are like in a world of their own, as I'm sure you're aware. And I don't have in front of me the numbers from the WHO. It is something that is treatable, that is doable in countries across the resource spectrum. In countries that are of more limited resources, there are certainly global funds, there are PEPFAR funds, there are many different sort of international agencies that provide funds for treatment. But even many countries now, because they really have very limited resources, are able to set up HIV treatment programs using their own public health funds, largely because of availability of low-cost treatments. The U.S. is its own sort of world with drug costs. How much would it cost in U.S. dollars to perform one test to diagnose HIV? You know that. An HIV test. How much an HIV test costs in the U.S.? I mean, it's free in the U.S. In terms of the cost of the test itself. It's not very much money to the healthcare provider, but we have free testing all over the country. So to the patient, it's free. In terms of the cost to the providers, it's a small amount of money.
This is Dr. Rizwan Naeem. I'm involved with HIV testing, so I can answer that question.
Excellent. I will refer to you.
Right. So if you are looking at immunological-based testing, which is antigen or antibody or both, the cost in US is not more than $5, $4 to $5. But if you're looking at viral load testing, which is for maintaining dose and monitoring the disease, it's cost about $50, $45 to $50. That is the cost to the labs. But what insurance companies are charged, very different. What patients have to pay, very different, but that's the cost of these two different type of mainstream testing. Thank you.
Thank you. And that's an excellent point. And I will say viral load testing is part of the U.S. treatment guidelines. Following viral load is not part of the general WHO guidelines for most settings. People really due to cost and wanting to look at sort of a public health perspective of distribution of resources. So we do use viral load testing here in the U.S., but again, it's not something that is actually necessary in most treatment algorithms. Next question is, what standard precautions do you take in HIV clinics, and what advice do you give family members and caregivers? So I talked a little bit about that on a couple of slides ago, but in terms of standard precautions, we see patients in clinic just like any other clinic. There really are there's no isolation precautions at all. We see patients, we don't wear gloves when we examine patients, other than obviously something you would normally wear gloves for, a gynecologic exam, obviously. But if you're just listening to people's heart and lungs, we don't wear gloves because we know that there's no transmission from casual contact. In terms of what we call universal precautions in the U.S., as I said, that's really when you're dealing with something sharp, like a needle, and it's when you are going to be exposed to blood or significant body fluids, not including saliva, sweat, or tears. What advice do you give family members and caregivers? In general, we tell people living with people who have HIV that they don't need to have any change in the way that they live together, other than the risk, being aware of risk exposures being blood. So if the person with HIV bleeds, you would want to make sure you use gloves to clean it up. And sexual activity. So we do tell people not to share things that would potentially be contaminated with blood, like sharing razors, for example. But in terms of daily activity around the home, there really isn't an exposure from casual contact. There isn't any exposure risk from casual contact. Eating around the table, sharing plates, sharing utensils, sharing cups, sharing dishes. There is a wealth of research around this, and it is not possible to transmit. So sharing a bathroom, sharing a shower, any of these things, it's really blood and sexual activity for family members. Anything else you want to add?
Yeah, I just want to.
Oh, how would you protect your staff? There was another question that came up. And how would you train your staff? So in terms of protecting the staff, I think that it's the same as us. So our phlebotomist, if someone is drawing blood, if our nurse or phlebotomist is drawing blood, they should use gloves. They should have a sharps container within reach of them, so they can, when they're done drawing the blood, they can put the needle immediately into the sharps container. So there's no risk of a needle getting lost in the sheets that they then, stick themselves on later on. But it's sort of the standard thing that you would use anywhere. You would do in any time when you're drawing blood. So gloves for anyone who's drawing blood. Sharps box is available in all the rooms, so if get something sharp, you can dispose of it immediately. But our staff don't wear gloves. Our staff don't wear, we have patients that it's all very standard. The training of staff is important because, as we talked about, people who have less medical training than healthcare providers may not be aware of that, and of the ways you can and can't get HIV. And anytime we have new staff members, we do sit down with them and really talk to them. We talk to them about respect for the patient. We talk to them about how important it is for patients to feel, like they aren't contagious in the clinic, that they're not putting anybody at risk in the clinic. So it's important to talk to staff about ways you can be exposed to HIV and ways you can't. And so that staff know, and it's actually not a hard algorithm. Like, sex is not really, a part of the clinic encounter. So it really is just blood and body fluids. And most people who work in healthcare settings can sort of conceptualize that and understand, these are the ways to protect myself. How do you deal with an accidental needle stick injury? So that's a key one. And that's a hard one. There are actually standard, what's called post-exposure prophylaxis guidelines, the general idea behind post-exposure prophylaxis is that if you are exposed to HIV, you want to take an HIV treatment medication for a period of time to prevent you from getting HIV. And post-exposure prophylaxis, if you know the patient has HIV or if you're unsure but